All right. Well, good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I would like to begin by acknowledging the traditional owners of the lands on which each of us are meeting today. For me, that's the Wurundjeri Wurrung people. And I'd also like to acknowledge the traditional owners of the lands and waters across Australia. I pay my respects to elders, past and present, and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generation. So firstly, a little bit of housekeeping regarding Zoom. If you have any questions throughout the seminar, you can put them in the chat, which can be opened using the chat tab at the bottom of your screen. We will have a designated Q&A session at the end of the talk today. So today's seminar will be recorded and uploaded to our website within a few days. Please keep in mind that if you turn on your video to ask a question, your image will be included in this recording. So today we'll be hearing from Dr. Clarissa Giebel, Senior Research Fellow at the University of Liverpool and NIHR Applied Research Collaboration at Northwest Coast. Her mixed methods research is focusing on inequalities in dementia care, and she's leading a national and international research with partners in Colombia, India, Uganda, and the Netherlands, as well as others. She's passionate about public involvement. Clarissa set up the public Liverpool Dementia and Aging Research Forum and hosts her own science podcast, The Aging Scientist. So today she'll be presenting the long-term impacts of the pandemic on the mental health of carers of people with dementia. So welcome, Clarissa, and over to you.
Welcome, and thank you very much, Bianca and Jess, for inviting me. I have to adapt again to giving a webinar talk now after giving face-to-face talks, so bear with me. It's all adapting, but I'm pleased to be here and speak about effectively a summary of some of the research that we've done as a group at the University of Liverpool to look at really who cares for the carers and really trying to understand the long-term impacts of the pandemic on dementia carers. So on the next slide, just bear with me. Where is it? There we go. So on this slide here, you see it's quite a populated slide. It's just to kind of give an indication of the research that we've conducted since the beginning of the pandemic, both in the UK, so nationally, but also globally. So for example, we've done a mixed method study, which I'll be talking about today, which started in April 2020, to try and understand what are the impacts of the pandemic on accessing social care and social support services in dementia, but also for the unpaid carers. We've also done a follow-on study, or well, a linked study effectively, looking at care homes and how the pandemic and the safe care home visitation has been impacted during the pandemic, both on family carers, on the residents, but also on care home staff. Because when we talk about carers, it's not just about the unpaid carers who are incredibly neglected, but also about the paid care workforce who are equally neglected and need a lot of support. We also have an ongoing PhD student. She's called Thais Caprioli, and she's in her final year at the moment, and she's looking specifically at how services, social care services in dementia, have been adapting to providing either remote or hybrid support, and what are the impacts of that, and where do we go next? So that's been primarily our nationally focused COVID research on unpaid carers and people with dementia. But we've also done global comparisons. For example, we've compared the findings from our UK study with Poland, Italy, India, and Australia as well, with collaborators in Brisbane. We've also done a specific lower and middle income country study where we looked at older adults with dementia, older adults without dementia, and unpaid carers, and how the pandemic has impacted them who are living in Colombia, India, and Uganda. So they're currently submitted. And I think one thing just to highlight as well is that it was really interesting to compare our care home research from the UK with Dutch collaborators from Maastricht University, because the Netherlands has handled the pandemic, at least in care homes, quite differently. And also globally, which I'll talk as well a little bit about, specifically on the unpaid carers angle, is we've conducted systematic reviews trying to understand what have been the early impacts of the pandemic. So really, I'll show you some of our findings from the community-based work, from our care home work nationally, And then I'll try and pull that together in the systematic reviews that we've conducted. So what have we done at the beginning of the pandemic? It seems quite a long time ago, but specifically now being in Australia, I think it just hits me how different countries are dealing with pandemics and the pandemic and the restrictions differently. So here, many people are still wearing face masks, trying to keep their distance as well. But in the UK, we don't have that anymore. We don't have any testing really either. So it's differently dealt with. And obviously in low and middle income countries, there's a different scenario as well. So I feel it's really important to still reflect on the findings that were generated in the earlier stages of the pandemic, because we will have another pandemic. We might have another stage of COVID-19 or other issues, and we need to understand how badly people have been affected to try and generate recommendations and guidance so that this does not happen again, or at least not to that level of severity. So what have we done? I'll first talk a little bit about the community data. So we were really lucky in receiving funding within about 1 week of national lockdown from the University of Liverpool. So we conducted 50 qualitative baseline interviews throughout April. That sounds a lot, and it was a lot. And it was a lot of information, really rich information. We heard from unpaid carers and people with dementia over the phone or over Zoom. But the thing was as well that so many people wanted to take part because they wanted to have an outlet for how things have been affected, because the government wasn't really there to support them. There was nothing or no one there to support them. So they wanted to have that voice really heard, which was fantastic for us. But also as researchers, I think we need to reflect that for both of these studies, which are linked, that there can be an impact on us as the research team as well, because it has been quite emotional data that were collected. So we had to support one another as well. We then, a few months later, conducted up to 20 follow-up interviews with unpaid carers and people living with dementia. And again, the community-based work was all about how is the pandemic impacting on you, but also specifically on your social care and social support service usage. So when we talk about social care, social support in the UK, we refer to peer support groups, social activities in the community, paid home carers, going to daycare centres or respite care, and it can also include long-term care or residential aged care. And how this idea for this work was generated is, I think, important to say, because throughout these two studies and throughout all of the studies that we do, we have lived experts, so that's carers and people with dementia. We have health and social care professionals, and we have charities involved as equal team members. So we've already had this type of group working set up. So what happened when national lockdown was imposed in late March was that a lot of the carers and people with dementia were contacting me privately saying, I'm so worried, my husband can't go to the daycare center anymore. I have to pick up all these additional caring hours, and I'm really worried and I'm anxious. So that's why we put all of our heads together and put together this idea for the work. Based on the community-based study, we then, and I'll elaborate in a few slides down why we then set up the care homes project, because some of the community-based findings led us to care homes and long-term care. So we were lucky again to receive some additional funding. And then we wanted to understand in this care home-based research, which was conducted October, November 2020, to understand what are the impacts of the pandemic on safe care home visitation, but also on how the care workforce is managing and dealing with this. So we recruited over 40 carers, unpaid and paid, and we recruited, including that, 16 care home staff from 16 different care homes across the UK. And we conducted some follow-up interviews as well. Just to mention, to put it into UK context, between October, November 2020 and March 2021, we had vaccination rollout. we also had increased testing. So in addition to that, in March 2021, there were 2 sudden announcements from the government, which I'll elaborate on in a few slides down, but it's important to mention here because the government suddenly announced very early in March that each care home resident can have 1 essential visitor. About 2 weeks later, they announced each care home resident can have 2 essential visitors. So they should really have people and families coming in. However, that was only communicated from the government to the media and not from the government to the care homes. So that led to a lot of difficulties, which you'll see in a few slides. So the first key finding that we found in our community-based work, so I'll talk first a little bit about the community findings, and really it's a summary. All of what I'm going to talk about today is published, so if you want to find out more, we've done a lot of sub-analysis on inequalities, paid home carers, the emotional impacts, etc. But really the key finding early on was the faster deterioration. So you see here a few of the quotes from different carers, adults, child carers, and they were saying within the first few weeks, so national lockdown was around 21st of March. We collected data up until the end of April. So within a few weeks, carers already noticed this faster deterioration. Now, there's 2 ways to explain it. We feel one is obviously the lack of stimulation. People were suddenly just left at home, weren't going to their support groups anymore, to the daycare centers, and we're really lacking that cognitive stimulation, the physical stimulation of actually getting out of the house or going to the supermarket, going to those groups, and the social stimulation. They weren't able to talk and chat and catch up with people anymore. The other thing is, we feel as well, and that was shared by some of the unpaid carers on our research team, was that it might be that suddenly the people with dementia were obviously staying at home and the carers had to take on more caring hours. It might have been that carers were more susceptible to actually witnessing, oh, actually, my husband, my dad is much more deteriorating than I thought because I spend so much more time with him or her. Because usually they'd go to a daycare center during the day or other activities. But this finding, the faster deterioration, was replicated in other studies as well, which we've evidenced in the systematic reviews, particularly the one looking at people living with dementia. But more research needs to show really how the severe impact of this. And I want to highlight here, focus on paid home care, because out of all the activities and types of support that we asked people about and were interested in, paid home care seemed to be specifically standing out. So we had some unpaid carers who were feeling it was just too worrying to have different paid carers coming into the home during the pandemic. They might potentially bring in the virus and potentially infect the older, vulnerable person with dementia. So they decided to stop paid home care. As a result, they took on those caring duties, and we know that their levels of burden, well-being have just increased. So higher levels of burdens, reductions in mental well-being and mental health as a result of this. Another group of unpaid carers decided, I am already so overwhelmed with providing care for my loved one, I cannot possibly take on these additional caring hours. So they decided, okay, it's really difficult, but I have to make the decision that those paid carers can still come in, whilst being fully aware that the virus might come in. And one thing to maybe put into context here, in the UK, it is not uncommon for a person in the more advanced stages of dementia, or for generally a vulnerable person who needs a lot of care, to receive up to 10 different caregivers, paid carers, a week. So that's obviously increasing the opportunity for the virus to be brought in. But it's also, if we think about the dementia, it's really difficult picturing that so many different members of staff come in if someone can't even recognize one person. So really difficult decisions there. But one thing I'd like to point out here as well is that we've spoken to some unpaid carers who were from more socioeconomically disadvantaged backgrounds, and they were reliant on state support, funding, or more rather local authority support to pay for this care. So they really were against having paid carers come in during the pandemic, but they were worried that if they were to stop this funding from the local authority, which it is in England, if someone is underneath a certain threshold, they get this financial support. They were worried that if they stop it, and then if the pandemic stops as well, they wouldn't receive that financial support again. So whilst they really were incredibly anxious and afraid of paid carers coming in, they were kind of reliant based on their socioeconomic status to have them continue to come in because they wouldn't get the support afterwards. So I think it also, the pandemic has only exacerbated those inequalities in accessing care and using care for dementia. So this has been a very swift summary of some of the findings on the community-based study. Really, just to summarize, there's been no support for carers in terms of care provision. Suddenly, social care and social support services pretty much weren't accessible anymore, except for paid home care. This resulted in generally poor mental well-being for everyone all around. And in our 3-stage survey, which we conducted between April and August 2020, where we asked people about their access to social care and social support, and established measures of depression, anxiety, care burden, mental well-being, we found a significant association between if someone does not get as much social care anymore and social support, their levels of mental health and mental well-being are reduced. So, but we don't want to keep all these findings in academia because sometimes they can just get dusty and not just for us academics, so there's no point, because we really want to try and make a change. So we've worked with the Liverpool Heseltine Institute and written up a policy briefing about the impact of the pandemic on people with dementia and carers, and we've made some recommendations for social care. And it's really these types of documents we feel that are more, I suppose, accessible then for decision makers moving along. Because as I said at the beginning, it's not just we found this, that's it, but we need to make changes because the trauma that has been experienced by carers and people with dementia is not just going away. They didn't have the support, so someone still needs to deal with this. And this is now the link over from our community-based work to our separate but linked care home study. So when we've done the follow-up interviews a few months later about the community residing people with dementia and their carers, we found that I think it was 4 or 5 people with dementia had entered a care home because they were deteriorating faster. And they didn't have that level of support from social care and social support services, and their unpaid carers just weren't able to cope with all these additional caring duties. So we wanted to understand, based on this, okay, so what's actually happening in the care home? Now, I've heard from some people I've met here, from some researchers, how the care home situation has been during the pandemic in Australia, but I'd love to have a chat about this in the Q&A as well. So what did we experience in the UK? Again, we collected data in late 2020. And at that time, and even at the follow-up interviews, many unpaid carers actually had not met their relative face-to-face or had any contact with them since the beginning of the pandemic. So many people were completely left separate. Where visits were enabled, which were very limited, there were pod visits. So for example, with a plastic screen in between, there were garden visits, window visits, as you can see here, and end-of-life care visits. And end-of-life care visits were a little bit different in that people were allowed to hold hands and be in the same room. But it was really strict. And not everyone was able to secure a visiting spot, which is, it's horrendous to really hear and read those transcripts and speak to people. On the other side, there were also a lot of remote visits, but remote visits are incredibly difficult. I mean, all of these types of visits have been incredibly difficult for unpaid carers. It's so emotionally overwhelming seeing their relative in such a far distance, but also for the person with dementia living in the care home. They don't often understand why they can't really see their grandchildren, their daughter, their husband, their wife, etc. It's that level of understanding just isn't unfortunately there for many. But then on top of that, if some people were engaging in remote visits, that is really difficult to understand for someone with cognitive impairment. To understand like a Zoom screen with lots of boxes, for example, if you go to support groups in the community, or if you have your family on the other side of your FaceTime, many of those older residents with dementia might not know the technology and get really confused. So there's no benefit to this. And on top of that, there had to be care home staff sitting side by side the residents for all these type of visits, for the remote visits to enable them, and for the alternative face-to-face visits to kind of ensure that the family was not actually trying to touch the resident and bring in the virus. So incredibly stressful for everyone involved, but also for the paid carers, for the care home staff. That's additional hours taking out of actually providing care for the residents in the home. So increased levels of stress for them. We have witnessed, so just again to put a little bit of context into this, there has been no national guidance on safe care home visitation in the UK during the pandemic. The Netherlands has been the first and probably only country during the heights of the pandemic to implement guidance from the government to enable safe care home visitation. That was introduced in the Netherlands in May, so very early on, and we've done comparative analysis with them, and it seemed to really support the well-being of everyone involved. It was still very difficult, but there were some benefits to it. There was nothing like that in the UK. So every single care home had to make their own decisions in terms of how to cope with the pandemic, how to manage infections, etc. And we've witnessed that some of the care home staff were telling us that they made individual decisions of changing visitation rights. So some care home staff witnessed that the residents were depressed, they weren't eating well, they were really missing their relatives, and it was so evident that it had a physical health impact on them. So in some instances, individual care home staff made those changes to visitation rights, but not all of them. And again, there was no guidance. And as I was alluding to before, when I gave you that slide about the data we collected, there was a clear lack of communication. Not just a lack of communication from the government, so from really high up to the individual care homes, but also family carers perceived there to be such a huge lack of communication from the care homes to them. Most of them weren't able to see their relative anymore, whilst before the pandemic, they might go in 5 times a week or 1 day a week or whatever, but they were continuously seeing them before the pandemic, and suddenly they weren't finding out anything anymore. So some care homes were good and created newsletters and updates or WhatsApp groups, but there were very few of those. And the majority of care homes did not provide any communication in terms of, well, you can see your relative, but you can't see your relative. And that just breaks down a lot of trust between the unpaid carers and the care home staff as well. And it's now thinking in the long term, that trust is broken down. How can we rebuild that? Because that's needed. And guilt. So guilt was a really heavily featured feeling and emotion for the unpaid carers. So speaking also to the unpaid carers as part of our research team, they were explaining to us when they themselves coded some of the transcripts, we supported them and trained them up to do some of the analysis. And they said it just resonates with them because lots of the participants had so lots of the caregivers had moved their relatives with dementia into a care home before the pandemic. And they already experienced a lot of guilt before then, because they felt, well, actually, I should really be able to cope. I should be able to provide the care. It's my mum, it's my dad. But they weren't able to, which is completely normal. There comes a point where some more support is needed. But on top of that, the pandemic, and especially some of those carers had moved their relative with dementia into a care home during the pandemic. Few of them, but some did. And that was especially difficult because they knew they were very unlikely to see their relative for a very long time, yet still they needed that extra support in terms of care. So that guilt featured in pretty much all of the transcripts that we read, in all of the interviews that we've done with the family carers. And it's just this feelings of being overwhelmed and this abandonment. The word abandonment featured so much. And going back to the relationship breakdowns, because there were different types of relationships that broke down. As I was saying earlier, when we looked at the types of visits that were enabled, the relationships between the family carers and their loved ones, because the relatives with dementia weren't necessarily able to understand, why is this happening? Why is my daughter not visiting me anymore for such a long time? But there's also this breakdown in relationships between residents and care home staff. And we have one activity coordinator here who put this really nicely in a quote. Because care home staff had to wear all the PPE, face masks, etc., and it's been made even more difficult then to understand for someone with cognitive impairment, someone with dementia, whether the care home staff is smiling, for example, but also care home staff had to ideally keep a little bit of a distance. So they weren't maybe as engaging, as close as normally. And we've also heard that some people were kept in their rooms as opposed to being able to obviously mingle within their care home, within the activity groups. So again, lots of relationship breakdowns, as well as between care home staff and the family carers. And this has been, well, not surprising in retrospect, but it struck us so much when we've done the follow-up interviews in March. So we witnessed a lot of frustration in family carers when we've done the baseline interviews. Completely understandable. They've not seen their relatives for such a long time. People were upset and frustrated and feeling a bit vulnerable, I suppose, about this. But then when we've done the follow-up interviews about 5-ish months later, we noticed the anger in relatives. They were still frustrated, but more they were angry, and they didn't have to say, I'm angry. It was so evident in the subtext to the text that they were really agitated about it. So why was that? As I was mentioning, there were supposed to be essential visitor rights, but they were not really implemented because care homes weren't aware of them. So that took a long time to actually take place. And the key reason for this level of anger was as well that carers were still unable to go and visit their loved one in the care home, despite all of them being vaccinated, testing themselves regularly, and really adhering to the restrictions. But then they're witnessing that COVID still made it into the care homes of their relatives. Well, how is that? That's because many care home staff did not get vaccinated, and care home staff were still able to sit next to the relative if you had a pod visit, if you had a garden visit or window visit or a remote visit. So care home staff who's not been vaccinated was able to go in, sit close to the relative, but unpaid carers weren't. So again, that no one seems to have supported carers to deal with this, but that anger is still there and is still lingering. So because that time can't be made up and can't come back, the time to spend time with your relatives. So we need to provide much better mental health support now, and we should have done before this pandemic, to the carers, both unpaid and paid. But what I want to focus on as well is that unpaid carers have been neglected and have not been supported at all. But paid carers the social care workforce, both in the home environment, but also in the care homes, have equally not been supported. So we've witnessed lots of carer burnout, and particularly for the care home workforce, just this increased levels of stress. Everyone was saying, I'm working much more hours. Someone was saying, I'm working now 70 hours a week or something. Sorry, there's a bin lorry outside. I hope you can't hear this in the background. So if there's noise, you know what it is. So this increased levels of stress, and again, there was no guidance for anything, no guidance to provide the care, to manage the infection risks, etc. So carers have not been supported either in the care homes. And this, very timely, has come out last month. It's a new report by the Health Foundation. It's worth a read. And it talks about the care workers in the UK and the cost of caring. So to put this into context, in the UK, the social care workforce is generally not well supported, not well trained. They have very little income. And it's generally not a prestigious job at all to work in. They're very unmotivated, and they're not supported by society or by the government or by the infrastructure to really flourish in the job, most of them. So what this report showed was that 1/5 of all the residential care workers in the UK live in poverty. So you can imagine the increased stress and burnout from the pandemic, on top of the stress that was experienced before, and then living in poverty. It's just a recipe for mental health problems and support needs. So that was a summary of the UK findings, of some of the UK findings on the paid and unpaid carers in the dementia field that we've done at Liverpool with others. Oh, Jess is coming on. Am I going over?
Oh, no. I was just anticipating that you might be reaching the end, so preparing myself.
All right, sorry, a few more slides.
Yeah, of course.
Okay, sorry. So now I just want to take us a little bit global and talk about the systematic review, which kind of, well, we try to understand what's the situation globally in the community, really, primarily, but also in the care home sector. So we've had a lovely team of international researchers and unpaid carers. So we had Kasia from Brisbane, and we also had René Turian from Germany, and a few of our UK dementia researchers, but we also had Jackie Cannon and Hilary Tetlow, who were the unpaid carers and team members of this work. So we were specifically quite broad because we didn't really know yet all the impacts and effects of the pandemic on people with dementia and unpaid carers. So we generically focused on health and mental health outcomes, cognition, and social care access and use. And we registered this before we started the review on Prospero. Now, as you can imagine, if researchers get really excited and are a bit too broad, they generate way too many records to be screened, nearly 10,000. So that search was conducted in mid-July 2021, and effectively every week new records were found. So what we decided was we focus on the early impacts of the pandemic. Otherwise, we'd have to redo this review over and over again and keep it updated. We were trying to be as narrow as possible, but still we wanted to provide an overview of the impacts and not on one specific outcome measure. And we didn't really want to kick out the good studies. So we ended up doing a two-part systematic review. We included 46 studies reported in 53 papers. And part one looked at the outcomes on people living with dementia. Part two looked at the outcomes on unpaid carers. And both of them are published in Aging and Mental Health. So if you want to read them, you'll find the other easily as well. The systematic reviews, both of them reported on evidence from 15 countries, including from low and middle income countries. Majority of them were conducted in the community of the 36 studies. And there really was a mix of survey, pre and since assessments, and qualitative interviews. So again, we weren't specific on the type of methods used. We wanted to have an overview. So looking at just part two, just the unpaid carers, because that's what the talk is about, we found a lot of evidence, mixed methods, quantitative, using established tools, but also interviews on the impact on access to care and support. And all studies were reporting on the negative outcomes on carer burden and well-being. And really there, as to be expected, was no positive impact on this. But just to highlight as well, there were some studies, for example, which had a rather different focus before the pandemic. But then because of the pandemic, they kind of shifted. So they collected data on, say, depression, anxiety, carer burden before the pandemic. And then they shifted their focus. So they had and redid the same assessments a few months later since lockdowns in their respective countries. And this is how they could show that actually carer burden increased and mental well-being deteriorated. But there's been lots of other evidence, and if you want to have a read and find out more about this, then have a look at this part 2 on unpaid carers. But really, again, just to highlight, the key message that came out in that review was the impact on poor levels of mental well-being, which, as we know now, are still not being addressed in carers. So what are we doing now? This research that we've done at Liverpool, but with lots of other collaborators and carers and charities, it led us to apply for some more money. And we were lucky to receive funding from the NIHR in the UK. And now we're looking at unmet mental health needs of unpaid and paid carers for older people with and without dementia. As part of this, it's an 18-month project. We're collecting interview data, remote interviews with home care workers, with care home staff and unpaid carers. We've done 34 interviews already. Majority of them are unpaid, because what we're experiencing at the moment is that it's rather difficult to recruit paid care staff, I suppose because of the increased roles and duties that they have to fulfill. But we've also noticed that some feel quite reluctant and apprehensive in, suppose, sharing negative experiences. So we really need to clarify to them at the beginning it's completely anonymous, and we recommend as well to conduct the interview in their own home, at least not on the side where they're working, because someone might walk in and they feel apprehensive. So yes, this will be really important to take that next step. After those interviews, we will conduct a series of focus groups with managers of the home care settings and of the care home settings, but also with care professionals to try and understand what's the access to mental health support like in your organization, or what support do you provide? Because what we want to do is then we'll have a series of co-production workshops to try and develop a mental health intervention, a really easily accessible, embedded within the community or within their organizations to access, support and discuss all these negative experiences, both during the pandemic, but also since. What's it like to care for someone? What's it like to witness people passing away in the care homes, for example? So really to summarize some of the key messages from our pandemic research, which are still really relevant now and have implications for now and going on, there have been increased caring duties without any support. And if that stays without any support, that will just deteriorate the mental health and well-being of carers so much more. There's been the same witnessed for care staff, so not just unpaid carers, but paid professionals as well. And it's just that dealing with loss that hasn't been dealt with at all, and the grief that people have witnessed. So what we promote with all of our research really, and the key message that we advocate for, is there's a need for ongoing and easily accessible mental health and care support. And yeah, so currently we're putting together a grant application onto this. So I think that's for me, yes. So I wanted to put photos of everyone on this slide, but unfortunately, or fortunately, we've had so many people involved in this, but I just want to thank obviously all the participants and the charities, including Lewy Body Society and Tide Carers, but also the many people with lived experiences, including Hilary and Jackie and Stan, and many more. So yeah, that's been me. So happy to answer any questions now. Thank you.
Thank you very much, Clarissa. So we now have some time for Q&A. If you'd like to submit a question, you can do so via the chat, or if you'd like, you can turn on your camera and microphone, and we'll be able to call on you in turn. Larissa, would you like to stop sharing your screen perhaps so we can?
Yes, sorry, just had a sip of tea, sorry. Bear with me.
Well, while you're all pondering your questions, Bryony, I see you've submitted some in the chat.
Yeah, I've got lots of questions. Some of them I've already put in the chat. One of the questions, and it's sort of, they go along with what you're presenting, so they kind of relate to different parts of the presentation, but we had the same issue. We had guidelines that were developed by a combination of advocacy groups that were agreed to by government and, you know, all the key people, and then but not all the care homes adhered to that. But one reason for that sometimes was that they'd actually surveyed their residents, and the residents said they didn't want visitors. So I was just wondering if you had any experience of that in the UK.
I mean, we didn't speak to residents because of the restrictions. It was impossible to get any of that. But
yeah, they weren't surveyed by researchers. They were surveyed by the providers. Yeah.
We didn't experience anything like that. No, it was more that residents seemed to be really upset about not seeing the loved ones. Yes.
Yeah, I'm not sure how common it was. The other question I had about that was, did you come across any, we also had family carers though, who actually found it a bit of a relief that they were otherwise having to go in every day and not having to do that, and being able to just go like visit via Zoom or whatever was like actually beneficial for them. I was just wondering if in your qualitative studies you got that story as well.
There's two things to this. So first answer is no, we did not experience this, but what we did notice was that care home staff, some, not all, actually said they enjoyed families not coming in because they felt residents were much more, as they put it, calmer, which actually is...
We had that as well, yeah.
Yeah, passive and just not having to deal with them being, I suppose, happy to see others. But the other thing was that, so we didn't notice that unpaid carers were happy about it, but rather that there were some issues between unpaid carers at times, especially when these essential visitor rights were supposedly coming in. They were then arguing, well, am I going to be the essential one, or are you, my brother, going to be that one?
Yeah, that would have been similar here, I'm sure. Anyway, thanks for your presentation. It's really interesting to hear about the UK experience.
Thank you.
Bianca, do you have a question that you'd like to ask Clarissa?
I do. I've got lots of questions. Thank you, Clarissa. That was really, really interesting to listen to. Look, I'll try and curtail myself maybe to two questions focusing on the care workers. So one is, do you have what we observe with, we've had very long lockdowns in Melbourne, is mental health tends to wax and wane depending on where the pandemic's at, what the lockdown restrictions might be, and if there is potential on the horizon for more lockdowns and more restrictions as opposed to just opening up. So do you feel, first of all, the first question, so do you feel if you repeated the work now that you might find different insights into people's mental health? That's the first one. But the second one, taking the point about care workers and what they've been through, and I was very struck by the comment that 1 in 5 live in poverty. There'll be a degree of PTSD, and how do we facilitate the recovery of paid care workers, especially in homes, in order to, I guess, retain that workforce as well? Because we've also struggled a lot with people just walking off the job, saying they've had enough.
Yeah, so in answer to the care workforce question, that happened a lot as well, because after we finished this data collection, at some point it was made mandatory for the social care workforce to be vaccinated, but because there was quite a bit of misconception, as in I might not be able to get pregnant, I might be microchipped if I get it. So quite a few social care staff then walked out of a care sector that's anyways not really well supported and well funded, so they didn't really miss it. So now it appears that there's even fewer people in the social care workforce, so we now need to build that up again. what was the other question, Bianca? Sorry.
Sure, it's more about mental health really kind of sort of waxing and waning depending on the restrictions at the time.
Yeah, I suppose if we did it now, we'd find more the lingering effects and the resentment about this is what it's been like at the height of the pandemic. But presumably the anger, for example, wouldn't be as high anymore, the mental health, because people have started to deal with it themselves in whatever way possible. Yes, it'd be a bit different. There's still impacts.
Thank you, Bianca. Joan, would you like to ask Clarissa a question?
Yes, thank you, Clarissa. A fabulous presentation. It's amazing the resonance and the findings. You know, the experience is very similar here. So the workforce itself, as you point out, you know, they're so disempowered and feel disempowered, and often in the past their concerns have been dismissed politically because they haven't had political voice. And so the conditions are structural and they don't have the capacity to change their conditions. I guess I'm on a bit of a rant here. I don't have maybe my question is how do we affect structural change so that this is a valued workforce? Because carers and caregiving is not globally valued.
No, and I think we as researchers in our team at times feels incredibly frustrated that we know this now, so what can we change? But there's so many structural issues that need to change as well. But maybe to compare, so I go quite a bit to Maastricht University as part of research collaborations, and it seems there that the care sector is much more motivated, supported, and acknowledged within society. So, for example, in the UK, people can leave school, I think, at the age of 16. So it's the GCSEs, might be equivalent in Australia. And then they receive a few weeks of training, and then they're effectively let loose on incredibly vulnerable population groups to deal with them, to support them, to care for them. But in the Netherlands, people tend to go to university, have a few years of a qualification, a degree, which is considered much better. And people are thinking, yes, okay, I want to go to work and care for vulnerable people. And I hear that from lots of staff that I see there. So it's a really big thing to tackle, I think. How do we improve the sector as a whole?
One of my colleagues from Canada or America, she said it's a workforce that's caring for people that needs to be cared for themselves in terms of their vulnerability.
Yeah.
Thank you.
Thank you.
Thank you very much, Joan. I have a question for you, Clarissa, about PPE and face masks, particularly like disguising or hiding smiles. I also imagine that all that PPE would be very difficult for people with hearing problems to be able to hear speech that's muffled, not be able to see someone's lips when they're talking. So I know through media that many attempts were made here in Australia to help make PPE less alienating, things like printing pictures of people smiling and putting them on their uniforms, or face masks that were clear so that you could see people's lips through them. What were common techniques to help alleviate PPE barriers in the UK, and were there any in particular that you like and would like to champion?
So I think at the time of data collection, there was very little. Still, people were still getting used and trying to scramble together PPE, because we had many care homes that were saying, we've run out. We only have a stack left for tomorrow. So then another care home offered them a lot. So they really had to support one another. But what we did witness as well was that, as you say, the clear masks, where you can see the lips and the smile, etc., they started to come in much more as well. And then there were some documentaries as well since our research, not on our research, but about the care homes and the care home sector, in that because effectively it was a bubble in those care homes, that some care homes dropped the PPE completely because they wanted to have the residents feel warm and comfortable and at home again. So they dropped them and actually gave them hugs, etc. So each care home dealt with it completely differently. But obviously then those care homes had to be even stricter on everyone needed to be vaccinated, everyone needed to test several times, etc.
Interesting stuff. Well, thank you very much for coming and speaking to us today, Clarissa. It looks like that's all the questions that we had. So everyone, would you please join me in thanking Clarissa with your clap reactions? This is how we do a round of applause on Zoom.
I love it. Thank you very much, Jess, for organising this as well.
Yes, well, thank you for coming and speaking to us today. Everyone, our final seminar of the year is going to be on the 6th of December, where Professor Joan Ostaskiewicz, Professor Katie Featherstone, and Dr. Tina Vatanen will be presenting the limits and ethics of autonomy and choice in older people who are care dependent. So please join us on Tuesday, the 6th of November at midday. And thank you all very much for attending our Seminars in Aging program.